Hormone clinic, sir, or not homeo clinic. Good afternoon, sir. I thank the organizers for the opportunity and happy to meet one of my teachers, Sundaram, sir. I did MBBS from Madurai Medical College, sir, 2006 batch. And again, I thank the organizers specifically for this slot because I believe there is a small interval between your lunch and onset of sedation. So hopefully I'll fit my talk exactly in that limit. So I'll be talking about time in range and how it has become the new vital sign in diabetes. And my talk is not sponsored by any CGM device companies, and I intend not to promote any CGM device companies through my talk. And again, my topic does not allow me to go into details of interpreting CGMs and other stuff. So I'll be specifically talking about, I'll give a brief introduction where I'll state the obvious things why we are favoring more patterns from CGMs than averages given by HbA1c. Then we'll speak briefly about data concerned with TIR and how guidelines have adopted TIR and how we can apply practically in our routine practice. So like most lifestyle disorders, diabetes being it doesn't have a cure at sight. So probably we try to make optimal utilization of whatever available resources that we have. So naturally, most of the time it keeps on evolving the management, and traditionally we assess fasting, post-meal plasma glucose, random blood glucose, and HbA1c. And hierarchy-wise, generally HbA1c is often the favored one, the glycated hemoglobin that could tell us a story about last 3 months. We diagnose diabetes based on HbA1c. We categorize severity as well as we categorize the level of control using HbA1c, and it has certainly served us well. It correlates well with the average blood glucose. It has a good correlation with future prediction of complication, has been adopted in all guidelines. Easy to tell to the patient, easy for them to understand, and I certainly don't think it's easy to measure, at least not in our part of the world where we get filthy reports, HbA1c report from point of care devices. Anyway, even though in many conferences where we speak about how we have moved from glucose-centric targets to organ protection, but still when it comes to one-on-one discussion with the patient, at least for keeping them motivated in the short and long term, numbers matter, and HbA1c has really served us well in that regard. It gives the patient some targets to get motivated and work towards that goal. And all along we know that HbA1c is not the ultimate way of measuring glucose control. It has got a lot of fallacies. It does not take hypoglycemia into account. It does not tell us about the fluctuations. It does not tell us about the inter and intraday glycemic excursion. Gets easily affected by common comorbidities that occurs with diabetes like renal disease. So we now know that we have to move beyond HbA1c. As its name suggests, it probably provides only an average picture of glucose control. So I won't say it is paradigm shifting, but it's simple evolution of common sense that we have moved from the triad to the pentad, where we try to take into account the glycemic variability as well as occurrence of hypoglycemia, so that we could make these people with diabetes live as good a life as their non-diabetic counterpart. For the uninitiated, I think this slide would have been shown in many of the previous talks as well. Glycemic variability, simplest way to explain, take 2 patients, measure blood glucose over 24 hours. Their mean HbA1c is similar, but when you see the pattern, patient A has smooth upstroke and downstroke above and below the mean, while patient B tends to have steep high upslope and downslope, and we want our patient to be like patient A and not like B. So this is what variability constitutes. So variability directly predicts the time of occurrence of hypoglycemia, which in turn tells us, or which in turn makes the patient predisposed for morbidity as well as mortality. And how we can measure GV is by measuring amplitude, the degree of excursion above and below the mean, as well as the time spent in a specific target. And these things were realized with advent of CGM. The very first CGM came way back during my school time in late 90s. Wearable device that measured glucose, interstitial fluid. I think the basic idea of CGMs is pretty known to all of us. Just to highlight the obvious fact that it measures blood glucose from the interstitial fluid and not directly from the capillaries. So there is always a physiological lag. in that sensor reading will slowly, it will fall behind the actual blood glucose measured with the glucometer and other stuff. When blood glucose is moving gradually upwards and downwards, the lag will not be visible, obvious. But when there is too steep rise or decline, the ketometer or the glucometer reading will always supersede that of sensor reading. So that is one, one fallacy of sensor, which modern devices are overcoming. So previously we had only professional one, now we have personal one, the real-time CGMS compared to the retrospective CGMS that we had. Previous CGMS were blinded to the patient, now it's real-time, announced to the patient. So this was the earliest CGMS that was launched in our country, if my knowledge is correct. And I still use this as the most common CGMS in my practice because it's being offered free of cost by most pharma companies. The other two real-time CGMS, which most of our patient uses, one from Abbott and another from Vixa 2 or Lynx, which actually patient told me that we are using these things. Compared to FSL, the newer one, the Vixa 2 actually does not need an NFC-enabled device. It simply gets connected to the Bluetooth. Only thing, it's from a Chinese manufacturer, so probably our patriotism might be a little bit damaged. The one significant drug interaction with these modern real-time CGMS is that ascorbic acid more than 1 gram can spuriously elevate the values. So it needs only LIMC-2 tablets to spike the sensor reading. So any quality of CGMS will be measured by mean ARD, absolute relative difference, calculated from a complex statistical formula. So among the currently available one, FS2 plus, the company is saying that will be the future. At least for the nearby future, it's around 8, and Lynx or Vixa 2 is around 8.88. So it's less than 10, it's good. So time in range is a major CGM metrics that we try to study in our patient. The duration, the time spent by the patient within their target range. So it has got TAR metrics include TAR, time below range, above range, level 1 and level 2. Each of them has a color code. Any new technology needs to be compared to the older one. So in that regard, TAR directly correlates with HbA1c. For every 10% increase in TAR, A1C drops by 0.8%. That's why we adopted that 70% cutoff. It literally correlates well with the 7% HbA1c, 6.5 to 7% that we target in most of our patients. Again, why we favor patterns more than averages? Just to highlight the same, 3 patients, all of them have a same HbA1c, but if you see the TAR, tells the different story. The first patient has excellent TAR, the second one little bit lower, and third one terrible. So out of 14 metrics that CGMS offers us, the consensus guideline in 2017 accepted 10 for a routine usage, and majority of them will be covered by the TAR metrics that include TAR, time above range as well as below range. Apart from the duration of CGMS matters, active period, it should be active for at least 70% of variable time, and it should provide GMI as well. Percentage CV is again a statistical measure that tells us how is the fluctuations of the blood glucose, and in most of our patients, less than 36% should be good enough, which means the GV is low. So standard way of reporting any brand's CGMS is via AGP. It has 3 parts. The first one is glucose statistics and time in range graph. The second one is the actual AGP graph that shows the summation of all the graphs obtained over a period of 14 days. And the third one is the daily AGP, daily AGP profiles. So we use this one to understand the daily pattern. Again, as I highlighted, my talk does not cover the intricacies of interpretation of AGP, but this is how it usually goes. We try to understand the low glucose or hypoglycemia part first, then we try to understand or try to correct hyperglycemia. Then we focus on glycemic variability. If patient has previous report, we compare with the same. Then make an action plan that is agreeable to the patient, which is most important. Going into the data, TAR has been supported by a wealth of data. In type 1 patient, it has been extensively shown that even 10% reduction in TAR elevates the risk of retinopathy and macroalbuminuria significantly. Type 2 patient, mostly retrospective data that shows that the prevalence of complication, especially retinopathy, spikes as TAR goes up or worsens. And previous retrospective data has clearly shown that TAR can be considered as a surrogate marker of all cause as well as CV related mortality in type 2 patients. So again, I will not discuss each data in detail. Overall, it has shown that any type 1 patient as well as type 2 diabetes patient with multiple dose insulin, various trials from various across the globe have shown that CGM devices, mere addition of CGMs to existing care, lowered HbA1c, reduces the risk of hypoglycemia, promotes time in range, reduces hospitalization, as well as improved work quality as well as work output as well. So CGM in pregnancy has been probably most debated one. Very first trial, the concept study clearly shows that type 1 patients who became pregnant with addition of CGM to existing care, clearly the neonatal outcomes improved. So globally it has been accepted in type 1 patient, either planning pregnancy or pregnant already, they should have a universal, the same TAR targets as adopted for a non-diabetic patient, non-type 1 patients. So Indian guideline advocate the same. The data regarding pregnancy with type 2 diabetes as well as in GDM is very thin. A recent RCT that was published last year clearly shows that application of CGMS has significantly increased TIR compared to usual routine care with the glucometer measurement in GDM as well as type 2 diabetes. And this is interesting. CGM can actually predict who or all will go on to develop GDM after 20 weeks. So this is a GLAM study report published in 2022, if I'm right. So the study clearly shows that any CGMS applied between 30 to 17 weeks can actually predict who all will go on to develop GDM. So we can, we can start the preventive measures earlier. But this study has a little bit practicality difficulty. We are still awaiting more data, and still we do not have a threshold for utilizing CGMS in this regard, that is diagnosing or predicting GDM. So based on this, international consensus says that any type 1 or type 2 diabetes patient, ideal time in range should be 70% at least. With time below range, the next target should be less than 4%, that is level 1. For time above range, less than 25. Time above range level 2, more than 250 should be less than 5%. And time below range, less than 54 should be 1%. I think these numbers are quite well known by now. For different diabetes populations, say those who are at higher age or at high risk for hypoglycemia, we relax our TIR goal to 50%. So naturally the time above range goes up. And here we try to avoid hypoglycemia. So the ideal time below range, there is no level 2 here. There is one level 1 time below range that should be kept less than 1%. So this is for high risk patient at higher risk for hypoglycemia. Pregnancy, the rule is 70, 80, 90. 70 is well supported by data. Type 1 patients who become pregnant. 80% thin on data, type 2 diabetes patient becoming pregnant. 90% they say for GDM. Again, these are time in range specific for pregnancy. It will not be feasible to achieve in most of our patients, I believe. But ideal thing is like that, right? So I think we should not be over enthusiastically treating to achieve that 90% TIR, at least in some of our patients. And we don't have that cutoff or exact threshold for time above range and below range for pregnant women. So CGM even now recommended from 2015 onwards, ADA says that use it for all type 2 patients, irrespective of their treatment modality that we are employing. They say that when we employ CGMS on top of existing care, it can reduce HbA1c by 0.8% as well as reduce hypoglycemia by 60%. So pragmatic indication, I won't say pragmatic, this is how I am using CGMS in my practice apart from whatever the guideline says. For type 1 as well as type 2 or on insulin, it's definitely a yes, all of us are going to use. But I use it for convincing the patient who recently gets diagnosed with diabetes but are not ready for therapy. If you give a HbA1c target, he or she might be wasting 3 months of their time spending at high glucose. So if you have a CGMS device attached, that might make them panic and might come back for treatment. And we can also use it to convince the patient to up-titrate pharmacotherapy and not rely on HbA1c. And those who are not ready for insulin, you can also, deserving patient, we can also convince them to start insulin. And in excellently controlled patient, young individual, most of the IT people will fall into that category. If they have excellent HbA1c, we can use CGMS to achieve even more good glycemic control by avoiding excursion. Then again, as I said earlier, still I use the blinded CGMs more because it's available free of cost. You can use it for educating the patient regarding dietary advices, for giving dietary advices, as well as lifestyle changes. It's easy for us because there is no real-time display to the patient. They will not panic. we'll see in subsequent slides. So upcoming indication, they say in hospital patient as well as peri-op patients, application of CGMS actually enhances outcome in terms of reduction in ICU stay. So adoption in our routine practice for type 1, all should have accessibility to CGMS. If we don't have experience with CGMS, we should ideally be referring them to a center who has experience with CGM if patient is affordable. All type 2 and complex insulin regimen, ideally CGMS should be kept as a universal practice. But what about the others? The guideline says use it for all. So to answer that, we should have two queries. One, either we are ready for, placing CGMS for all of our patients. We should be comfortable using that, and when I say we, it does not mean us. We should have a trained educators. If our center has such kind of service, if we can provide that, we can use it for all. But ideally, like me, if you are practicing as a standalone physician or specialist, it's very difficult to manage. And is currently available device in India good enough? I had a terrible time with the earlier versions of CGMS in pregnant women. Now the company says that the recent version is quite good for pregnancy, but still I'm not convinced regarding their applicability in pregnancy, whether we should be, whether we should be advocating CGMS for all our pregnant patients. So quality compared to the Western devices still slightly off, but it's improving. And last but not the least, you can consider it as a take-home message. Adverse effect of CGM. Textbook may say that the only adverse effect is contact dermatitis. But in our practice, when we apply CGMS in our routine setup, the first thing that major adverse effect is tsunami of data, right? Both will be overwhelmed if you are not very comfortable with using CGMS, and patient will definitely get panicked after seeing so many values. All those people who thinks that they have excellent glycemic control, when they give CGMS, they'll be terribly shocked to see that their glucose level is going haywire. So ideally, CGMS, if we are applying CGMS, we should have a 24/7 support system. But if you are running a business or only clinic like me, it gets tricky. The second one, time thief, right? TAR prolongs TAR, the time spent by the patient in the room. I am sure this is an old joke, but I am repeating it again. Once you apply CGMS, you need to spend certain amount of time, which will not be less than 20 minutes if you are explaining it by yourself. Again, if your staff is getting trained to explain the same, still it will take a significant amount of time of the staff. So we have to find some way to make it as a billable service. Selling CGMS device will not be that, will not cover it, the time lost with a single patient. It may be easy for the initial beginners when you have less than 20 patients in our clinic per day, but it gets really difficult with time as time goes. So it's definitely prolongs the TAR in your room. Then again, the most major drawback or adverse effect I would say is that it might reinforce dietary misbeliefs of the patient. We still live in a world where we think that eating wheat is good, eating rice is bad, eating mango is bad. All these things are still circulating among us. You think of the patient still, they will not understand the difference or the influence of fat or protein that makes the glucose excursion. They will eat something, they will see the chart, or they will see the real-time flashing of CGMS. They might mark the fruit as evil. Most of the bananas get marked as evil because of CGMS, and many a time when they go for eating some crappy things outside, that may not actually increase the CGMS graph. Most of my patients come and ask me, when I eat barotas at the roadside stop, my CGMS is perfect. When I eat homemade idli, the glucose spikes. So these kind of basic education, these kind of misbeliefs are quite common. So we need to see who is sitting across the desk, whether he or she can understand all these differences. That should not make them have more misbeliefs or should not reinforce their existing misbeliefs. So again, last but not the least, it can cause significant diabetic distress if we employ CGMS for all our patients. I am sure 80% of the patient will go absolutely berserk if you apply CGMS. They will not be able to accept those kind of data. They will not be able to accustomed to seeing such kind of values. So we have to see very carefully, forget that eligible patient, type 1 patient as well as type 2 on multiple dose insulin. If you are planning to apply it on a wider range of patient, you should be prepared, your health infrastructure should be prepared to handle the same, and you should think across the table, who is sitting across the table, whether he or she can manage those kind of data. So with that note, I wind up my presentation. Thank you.